see me, drop a little message. Got it. In case you didn't get that pop-up, this meeting is going to be recorded, so you can watch it on playback at a later date, which you may well like to do because I have a feeling we're going to be going through an awful lot of information in the next hour. So a little bit of housekeeping stuff. If you are on laptop, to the right-hand side of your screen, there should be a chat box option. If you haven't got that option, it will be listed at the bottom of your screen. So click on that and it will allow you to send messages to us for us to answer. So for those of you that haven't done one of these before, haven't been to one of these before, my name is Jo Southall. I'm an independent occupational therapist, and I have been running these live streams for a very long time, answering your questions as we go along. I have recently started having guests, and this evening we have a very special guest, the wonderful Jeannie Di Bon, who is here to share all of her wisdom. So between us, hopefully we can answer most of the things you want to know. I do have a lot of pre-asked questions, which I'm going to make a start with first. So any that have been sent in advance of this meeting will do now. If you have questions that you would like to ask, please pop them in the chat box now. We will get through as many as possible, but we have had a record-breaking number of sign-ups for this event, so over 100 people. If all of you show up and all of you have questions, there is absolutely no way we're going to get through everything, but we will do our best. What I might have to do is just pester Jeannie into coming back at some point in the new year, and hopefully we can get through some of the other questions then, but we will see what we can do. Jeannie, would you like to tell us a little bit about who you are and what you do, just for the people that maybe haven't come across you before?
Well, first of all, thank you, Jo, for inviting me and the HMSA. Really happy to be here. So those of you who don't know me, I'm a movement therapist, and I work with people with EDS, HSD, chronic pain. So I have a clinic in Wimbledon, but I also see people online. And my job really is to look at overall movement patterns of people and where restrictions are, what might be moving too much, what might be moving too little, where things might be hurting, and basically improving people's functionality and hopefully reducing their pain through movement.
Amazing. So, happy to dive right in with some questions?
Yeah, absolutely.
So, question number one. My little boy is 15 months old and is extremely hypermobile. He's developmentally delayed, vocalizes but doesn't babble, and has only just learnt to crawl literally in the last few days. Can't yet pull up on furniture, reaches for things but doesn't point, and isn't great at feeding himself. I'm also hypermobile, as is my first son. So chances are my 15-month-old has inherited the hypermobility from me. However, though we are symptomatic in other ways, neither myself nor my eldest son were ever delayed. Because of this delay, my son has seen a geneticist, had bloods taken, done all kinds of testing. They're still awaiting blood results, but the MRI was clear and the geneticist didn't feel that any obvious abnormalities were a thing. The physiotherapist has been pretty great and pretty confident that his delays could be solely down to his hypermobility, meaning he will eventually catch up. My question is it possible for hypermobility to cause the delays I've mentioned? I've had conflicting advice from various healthcare professionals, so would love some feedback from the experts. Many thanks.
That's so weird. I was actually just reading some research this afternoon about crawling and developmental delays in hypermobility. So that's really weird. You must have read my mind. Yes, absolutely. The research, I came across two papers and both of them confirmed that being hypermobile can lead to some developmental delays, such as delays in crawling, delays in standing, delays in walking. I certainly didn't crawl myself. So, it doesn't mean that they're not going to catch up. They did also say that people with hypermobility might crawl in different ways. And I certainly crawled in a different way. I would kind of shuffle along on my bottom sideways to get around. But I didn't go through the actual crawling phase. So yes, there is research to support your theory. But again, I wouldn't think it's anything to be concerned about at this stage. He's still very young, and things can change over time. So I wouldn't be unduly concerned. And it sounds like you've had all the testing and everything done, so that's really reassuring.
Excellent. Yeah, I totally agree. I think there are times where testing and diagnostic stuff can be really useful, but equally, my personal approach to most things is to focus on the management regardless of the kind of root cause. So if you've got a physiotherapist involved, you've got an OT involved, you've got kind of the right support in place, you're doing all the right things, and focus on that. And if it ends up being a bigger problem down the road, that's maybe the point where you can get kind of extra focused in on key issues. But it does sound like you've got a good team around you who are quite proactive and quite involved, which is a really good thing. So lovely. Okie dokie. Happy to move on to the second question.
Yep.
So my 12-year-old daughter has hypermobility, 8 out of 9 on the Baton scale, and is keen to go on the school ski trip in Feb 2025. So there's plenty of time to prepare. I know each child is different, but do you have any advice on steps to take to strengthen your body for a novice ski trip? Many thanks.
Oh, wow. That's exciting, going on the ski trip. Yeah, so dealing with something like this, if there's a specific project that we're focusing on, like skiing, we're going to say, look at what kind of movement patterns are involved in skiing. So what is she going to need? She's going to need, strong legs, knee stability, ankle stability, hip stability. We're going to need some shoulder stability because she's going to be probably holding the poles. So we want to be doing things like leg work. And on my YouTube channel, I've got loads of exercises, loads of classes, but, building up to things like squatting and lunging and sidestepping, because of course I'm a terrible skier, and I've retired from skiing because I really didn't enjoy it, but I would always snowplow because now I understand why, because I found being turned out so much easier than being in parallel, because parallel is going to require those adductors, those inner thigh muscles to really stabilize, and the glutes to stabilize, which of course can be problematic for us. So lots of glute work, lots of thigh work, lots of ankle stability, all over body toning really. But she's got plenty of time. So if you do little and often now, if it's 2025, you're going to be fine by then. And make it fun. You can make it fun, standing on one leg, throwing a ball to each other, big gym balls, sitting and balancing on a gym ball, all sorts of fun stuff. Doesn't have to be boring. And it's because she's got a goal to look forward to, she'll be motivated to do the exercises. So sounds exciting. Really good.
Fabulous advice. Yeah, I definitely think as well, the best practice for doing a thing can often be the thing itself. So if you've got access to a dry slope near you, get some lessons now. Start speaking to instructors, start taking some advice. Really random things, like a lot of people find that ski boots are actually really brilliant foot and ankle support, but they change the way you walk, and that puts a lot of pressure on your knees. So getting a little bit of advice around that and practicing walking in ski boots is probably going to be quite helpful. The other thing that might be worth looking into is compression clothing. So for those of us with poor proprioception, poor body awareness, it can be really helpful to have a bit of compression because it kind of gives your body a bit more accurate starting information. So if you think of proprioception like those maps you get in shopping centres with the "you are here" arrow, the more accurate your starting point, the more likely you are to accomplish your task without walking into a door frame or tripping over your own feet. So that compression clothing can be a really useful way to just kind of boost your body awareness, but it's also great for staying warm, particularly if you've got the kind of rubbish autonomic dysfunction based circulation that so many of us do. So get yourself some compression leggings and see how that goes as well.
I'm just talking about the compression research. There was a new research study just came out about how wearing compression clothing can help with balance and proprioception in hypermobility. So skiing obviously is a big act of balancing. So great. If compression clothing helps with that too, even better. Great idea.
Fabulous. Okie dokie. Question number 3. I'm having difficulty with breathing when laying on my back at night. I even have a surgical pillow, which should help keep my head in a more neutral position. The pillow was given the okay by a general physiotherapist, but whether I use it or a standard pillow, I have the same issues. My neck seems to be too bendy and obstructs my breathing, albeit briefly. Any advice for strategies would be appreciated.
Gosh, right. So obviously it's hard to say without seeing you and without knowing your medical history and whether you've got any neck instability or breathing restrictions. So I don't know if you've tried propping yourself up a little bit higher. So some people can find that maybe if your head is too far tilted back or too far tilted forward, that's going to be compressing that area. But maybe doing some gentle relaxation and breath work before you go to bed, even in a seated position, just to calm things down, because maybe there's also some anxiety now about the lying down and the sleeping and the breathing. And that alone can make us a little bit, oh, I'm a bit worried about this. So maybe doing some gentle meditation, some gentle softening and breathing work before you get into bed. And maybe just propping yourself up a little bit. I don't know, Jo, what do you think about that?
It's a complicated issue. When you start bringing neck issues into anything, it always gets more complicated. I almost wonder if this is the sort of thing that would be worth a referral for a sleep study. So sleep clinics are a thing. There aren't many of them. They often have quite complicated referral processes, but what they can do is really kind of hook you up to 9 million pieces of machinery that make it very difficult to sleep. But what they would be able to tell is whether your kind of oxygen saturation is really taking a hit from this, whether it is, because we can feel breathless but still be getting enough oxygen to be safe, versus whether you're feeling breathless and you're not actually getting enough oxygen to be completely safe and well. So I definitely think a sleep study would be a sensible thing to do. In the meantime, definitely sleeping, maybe try being propped up a little bit more. The other thing that might be useful, and this is going to sound a bit weird, but get somebody to take photos of you laying in bed. Because for those of us with the rubbish proprioception, as mentioned before, we can think we're lying in kind of neutral, relaxed, normal people positions, but we've actually curled ourselves up in human pretzel mode and just haven't noticed. So it may be that if you look back at those photos and videos and you can see yourself kind of hunched up or like slumping to one side, you may be able to spot some postural issues that you just haven't noticed through doing them. But yeah, that might be something to mention to the GP as well. And a sleep study would probably be a sensible thing to look into. Yeah. Okie dokie. Okay. This is a question about a bed cradle to keep the covers off slipping ribs. So the foot cradle doesn't extend high enough to kind of keep the covers off. Couldn't find anything on NRS, but would a bed table be adapted? Maybe. So for those of you that maybe haven't come across this, a bed cradle is basically a little kind of shelf that you put under the covers in your bed. And they're typically used for people who are recovering from maybe foot or ankle surgery or knee surgery to keep the weight of the covers off your body, basically. They can also be used for conditions like CRPS, where touch is really painful. Or if you have particularly lax ankle joints and you find that the weight of the duvet is enough to subluxate your ankles. Although ankle splints for that can potentially be a better solution. The difficulty with bed cradles is that they're designed for smaller parts of your body. So if you're trying to keep something off your entire torso, you're going to need something a little bit bigger. An overbed desk may well be a good thing to try because they do go a little bit higher and they also extend maybe further across the bed as well. But what you don't want to be doing is kind of trapping yourself under a desk, forgetting about it, and then trying to get out of bed in a rush to get to the loo and finding yourself tangled up in your covers and bed stuff. So if you are going to go for that approach and you're using a table that's like a one-sided kind of right angle, see if you can get the table on like the wall side of your bed or the side of your bed that you don't normally get out of, just to kind of prevent yourself from basically getting stuck. That might be a good way to go about it. The other option potentially is to basically kind of modify your covers so that you've got like a different duvet on the bottom half of your bed, and then like warm, snuggly things across kind of your shoulders and arms. So it may be about actually just getting rid of the heavy stuff in the middle and kind of removing the problem, but keeping you in maybe like merino thermals or something really lightweight, but also really warm as a way to keep kind of snuggly. Electric blankets, again, you can lay on those as well. So that would be something that's keeping you warm, but isn't adding any weight to your torso. Any tips for that? Because I know ribs are quite a common problem among us squishy bendy folks. So
those are ideas though about the really good idea. Yeah, I mean, with on the other side of it, sort of the management of the ribs and the slipping rib syndrome, I'm a huge advocate of, breath work and finding a bit more buoyancy in the thorax through softening the thorax. And, I've had great results with that and helping people with the slipping rib and the subluxations by actually, it sounds counterintuitive, but actually softening the rib cage a little bit so that it can actually move a little, which you might think, oh no, that's the last thing I want. But so many of us have these sort of fixed, rigid torsos or thoraxes, because a lot of us obviously do brace to hold ourselves up, and we carry a lot of tension up here. And then that, in my theory, is that tension, when you try and move, it's not allowing enough expansive movement. And so you actually move, and because everything's so tight, it's enough to cause that subluxation. So a little bit of breath work, a little bit of softening. Again, lots of stuff on my YouTube channel about how to do that. I found that really, really effective with rib issues.
excellent advice. Thank you very much. Okie dokie. Next question. Hello there. Okay. Can I ask a couple of questions regarding hypermobility syndromes and driving aids? Cheers. Okay. So driving aids are an interesting one. There is actually a thing called a disabled driving centre, and it's actually a specialist field where there are people who are specifically trained to keep disabled people on the road. And it's their entire job to adapt vehicles, to look at seating, to look at positioning, to look at skills training, specifically around kind of driving. This is separate from like the Motability scheme, so you don't need to be on benefits to access this. But if you just have a look at your postcode and disabled driving centres, there are a few around the country that do give you basically like options where you can go and try all this stuff out. So that would definitely be my kind of top piece of advice there. Driving aids tend to break down into a couple of categories. There's things that you do to make your vehicle physically easier to drive, but there are also things that allow you to get in and out of your vehicle more easily. Because for a lot of people, it's the whoops, I sat still for 2 hours of motorway driving and now I can't get out of my car type problem that really gets them stuck. So there are two pieces of equipment I think are particularly brilliant for driving. No, three. There are three pieces I think are brilliant. The first one is compression gloves. Having your hands up and not moving very much on your steering wheel with the kind of rubbish autonomic circulation that many of us have. Cold hands, numb hands is a big problem. And trying to get into the habit of moving your hands regularly is really, really important. So there are quite a lot of exercises out there as well. I know Jeannie's detailed some of these that you can do sat down that you can do whilst driving. And I know this because my mother and I both nag each other into pelvic tilting on the motorway when we've been in the car for too long. But yeah, so things like every time you go past a speed camera, wiggle your fingers one at a time just to kind of get your circulation going. Or every time you overtake a lorry, check what your core muscles are actually up to. Start paying attention to your body, that kind of thing. In terms of physical aids, I think there are two that I recommend regularly. One is the handy bar. So this is literally just like a little kind of hook piece of equipment, which I can't quite reach. But it slots into the locking mechanism in your door so that when you get out of your vehicle, you have a handle to push up on to get out. And it makes a big difference because pushing actions when getting up are often an awful lot safer than pulling actions, because we tend to pull ourselves apart. So handy bar is a really good one. The other one I really, really like are like swivel cushions. So these are two pieces of slippy fabric circle discs that rotate on each other. So what it allows you to do is to sit on your car seat and then rotate your body around really easily so that you can stand up straight rather than doing the awkward sideways step thing that makes your hip fall out if you're not paying attention. So I think those are my favorite ones, but definitely if you're having significant problems driving or you can foresee significant problems with driving, get yourself to a disabled driving centre and see if you can speak to an expert for that. Anything to add?
No, I don't. I just learned a load of things there as well. Thank you, Jo. I didn't know.
Well, I love these sessions. I always learn something from my co-host.
Yeah,
Brilliant.
that's good.
Okie dokie. Is it counterproductive to use a brace to correct posture? So the pain consultant advised against using one to correct neck, back, and shoulder curve or rolling. Thoughts?
This is a common misconception, isn't it, that using braces is going to be bad for you in the long run. And I'm sure Jo and I are on the same page here, but no, it's not detrimental at all. You know, they can be really, really helpful for certainly from proprioceptive purposes as well. And sometimes we just need a little bit of help, right? And what's wrong with that? If I need a little bit of support, you know, and there's so many different things out there to give us a bit of support, what's wrong with that? My only caveat to that would be we can't rely on them 24/7. So it's not that I wear a brace and then I'm not going to do any exercise or movement because this thing is holding me up. So I'm not recommending that. If we get braces, same with orthotics, people think orthotics are bad. They're not. But as long as you're doing your foot exercises or whatever exercises, you know, whatever brace it is you're using, you got to still do your exercises for that particular area. But absolutely not. They're not detrimental at all. They're, you know, really essential for many, many people.
Yeah, totally agree. Totally agree. I tend to talk with people about activity splinting. So rather than looking at your maybe body parts or recurrent injuries. So as an example, I have really hypermobile wrists. They subluxate and dislocate very easily. I have multiple sets of wrist braces for different tasks, but I don't wear them all the time. So in a situation like this, where I'm sat still, I'm not lifting anything heavy, there's minimum risk of an injury, I'm not splinting. If I'm lifting a saucepan full of boiling water, you bet I'm putting wrist braces on. So thinking about specific tasks and how we can protect our body to do those can be a really good way of working out whether splinting is a good idea or not. If there is a task that repeatedly and consistently leads to injury, you are only going to hold back your rehab by not protecting your body from doing that. So if you can protect yourself from the things that break you badly, and then you can do your rehab on top of that, and you can get that inflammation down and you can get all that muscle damage to recover, that's how you start getting over those plateaus where you'll get stuck at. So yeah, fabulous. Okie dokie. Please could we ask the experts if hypermobility can cause ongoing tummy problems? Despite using Senna for 18 months, our 18-year-old daughter still doesn't have an urge to go unless she uses it, and it still doesn't always work. Her gastro doctor said that hypermobility can cause the bowel to stretch, but they expected the Senna to kickstart the bowel again, and it kind of hasn't. Anything to share there?
Well, yeah, absolutely. It can obviously gastro issues and different things. Some people have very slow motility, so yeah, constipation, blockages. Other people have fast transit, so they have the other problem. It can present itself in so many different ways. And obviously, I'm not a dietitian or a nutritionist, so maybe talking to somebody who is qualified, who can give you specific advice on that. That might not be the right product for your, I think you said your daughter, that might not be the right thing. So it's always good to speak to somebody who knows more about this. But yes, absolutely, it can cause, unfortunately, all sorts of problems in our gut.
Yeah. I definitely think dietary modification has been really, really beneficial to an awful lot of people. Unfortunately, there isn't a consistent dietary modification for everyone. People will find that they are kind of unable to tolerate certain things, but for other people, that's absolutely fine. So dietitians can do what's basically known as an exclusion diet, where they will get you to eliminate certain things and reintroduce them one at a time to work out what's actually causing the problem. This done in combination with things like Senna to kind of boost your bowel function. There are also medications that are aimed at specifically like speeding up bowel transit. So prokinetics, I think, is a technical term. So it's worth speaking to a GP about that to see if you can get a dietetics referral. But yeah, the diet that I think most of my clients have benefited from is called the low FODMAP diet. There is information online about this, but the exclusion part of it is both boring and complicated. So it is worth doing with support from a dietitian to get you through that, to make sure you're not missing out on nutrients or anything. In terms of how long you've been on the kind of Senna, I think the difficulty of hypermobility conditions for a lot of people is that progress happens very slowly. So in 18 months, I wouldn't really be expecting a massive amount of progress for anything, really. So it may be that she will get that reset situation that the gastro doctor was talking about. It might just take a little bit longer. So I would definitely go back to gastro, definitely have a look at kind of dietary stuff. But equally, like abdominal massage has been really useful for a lot of people. And you can find information and leaflets about that on NHS websites. So if you look for NHS advice on abdominal massage, hopefully a little bit of a tummy rub might help with that as well.
And movement, movement can stimulate the gut. So some taps and some, side rotational movements are very, very good for helping the digestive tract along. So I call them windscreen wipers, lying on your back and gently rocking your legs and your pelvis from side to side, as long as obviously it doesn't hurt. But that can be really helpful in stimulating a bit of movement there. So if you haven't tried any gentle movement, you could try that as well.
Fabulous. Okay, so this question from somebody who's not been to one of these before. So nice to know we've got some new people popping up. So I was diagnosed with Graves' disease and have been having far worse pain issues over the past few months. I have been told, almost as an aside, that this overactive thyroid issue can cause increased pain levels and decrease your ability to manage pain, but I wasn't given any more advice or information other than that. Is there anything that could be done to better manage hypermobility and Graves' disease together? Oh, it's so frustrating when you get the, oh, by the way, your pain's about to get loads worse, but we're not going to offer you any support on it situation. Pain management, I think, is really best done in a kind of multidisciplinary way. So this is why one of the reasons I do like pain clinics as an option. So a pain clinic is something you can be referred to on the NHS. Pain clinic is typically made up of a range of different professionals all working together to offer support. And it will often be led by like a pain specialist consultant, but you will also have anesthesiologists, you'll have OTs, you'll have pain specialist physios, you might have psychologists, because dealing with pain can make you miserable really quickly and your mental health takes a hit from that. All of these people together can often find the right combination of things that work really well for you. For most people, one approach to managing pain isn't going to be enough, or it's not going to be consistently effective. So things like pain medications absolutely have their place. They also tend to have an awful lot of side effects. Things like massage or acupuncture or TENS or hot baths, cold, hot water bottles, all these kinds of things can be really, really good in combination with that medication-based approach. But also learning to listen to your body with regards to activities that are maybe likely to cause a flare-up. If every single time you go to the gym, you get a 3-day flare-up afterwards, then we need to really look at what you're doing in the gym that's aggravating your body so much. So symptom diaries during changeable times can be really useful, because you can start looking at patterns as to what's really, really aggravating your body. And if you're dealing with a new diagnosis, working out what the problem is, what the pattern is the first kind of stepping stone towards finding the right management approach. So I would definitely say a referral to pain clinic is not an unreasonable thing to ask for. I would also have a look at doing a symptom diary for, say, 2 weeks and taking that to your GP and having a look at what you can do to specifically modify tasks that are really causing those flare-ups. Anything to add to that one?
Yeah, no, all good. I mean, the people I see in my clinic are all, the reason they come to see me is because they're in pain, whether that's EDS related pain or some other type of pain. So yeah, pain clinic, absolutely agree. My strategy for dealing with pain first is trying to calm the nervous system down. So we do that through breath, through gentle relaxation work. Again, lots of things on my YouTube channel to go through that. But when you've been in chronic pain for a long time, as you probably know, everything's going to get ramped up. Yeah, we're going to get more hypervigilant, we're going to get more sensitive. So what can we do for ourselves in our sort of self-management to help calm some of that down? And I found breath and relaxation. And that's what I teach first before we start doing any kind of movement. Because so many people, as I say, most people who come to see me are in pain. So we work on that side of things first before we even think about doing strengthening and stability and all of that, which is good stuff, but we need to kind of dampen things down a little bit first. But that would go hand in hand. As I say, that's, as Jo said, it's not going to be one thing. It's going to go hand in hand with lots of other multidisciplinary approaches to deal with pain, because pain is so complex, absolutely complex. But yeah, start working on calming things down a little bit as well to add to your toolkit.
Brilliant advice. Thank you very much. Okay, so that's our pre-asked questions done. We're halfway through the session and we're only now getting into the chat boxes. So our first question there is, would you recommend dynamic fabric supports to help people learn what good posture feels like? So with these, what we're talking about is something like DMO or job skin. So I've got my demonstration ones to the side here. So what we're talking about here are compression clothing items that are made bespoke. One layer of Lycra is the kind of basic, and then what you do is you build up extra layers like that over areas that are maybe more unstable or to encourage your body to move in certain ways. The real benefit for these is that they are totally customizable. So these were made specifically for me, specifically to fit my bum, my hips, my thigh joints. They are reinforced in the areas where I specifically have instability and where I need that extra boost, which makes them basically useless to anyone else, but brilliant for me. The other benefit for these is that one of the main difficulties people have with compression clothing is getting it on and off without damaging your hands, your wrists, your fingers and thumbs. So having something like this, you can build zips in. And if you've got zips built in, you can unzip your legs, you can shimmy in, and then you can do the zips up with a dressing tool. And it's a much, much safer way to get in and out of compression clothing. I am a massive advocate for this style of splinting. I think what it does is give you a huge boost in proprioception and in body awareness, a gentle encouragement to have good positioning, but it's not likely to do so much work that your body gets lazy from it. It's also not going to cut in too badly. You're not going to get Velcro to too many other things. It's a pretty wearable thing under regular clothing. And because it's softer, it's a lot more comfortable for those of us with POTS issues who maybe need to be horizontal for a decent chunk of the day. So I am a huge advocate for this kind of thing. I think they are brilliant. It is available on the NHS. So if you think that compression clothing like this works really well for you, if you're the sort of person that finds tuber grip works or the sort of person that finds kinesiology tapes really, really beneficial, this kind of thing basically combines those both, but in basically Lycra clothing for you. I would ask your GP for a referral to orthotics. It does take a specialist training to fit this clothing. If your orthotist is not trained in fitting it, DMO can send somebody out to do the fitting and measuring for you. So it is available as an NHS thing. You can also do it privately, but I would strongly recommend not doing that simply because of the price tag. So yeah, hopefully that's given you some tips, but definitely I've shared some photos of mine and some advice about mine on my website. But yeah, definitely it's something that I'm a huge advocate for. I think as far as splinting goes, this is one of the better options for people with widespread joint issues.
Amazing.
Is this something do you come across this quite often in your work or not much?
Not necessarily, but I do refer people. People are always asking me, should I get compression garments? And I'm a huge fan of them, absolutely. But yeah, that was a beautiful explanation. So yeah, great.
Lovely. Hopefully that's helpful. Okay, next question. Do you know of any supports or strategies to support kids with good seated posture? We have lots of great strengthening exercises and games, but still sitting is a challenge for my 8-year-old godson. Sitting is a challenge. It's one of those, everyone seems to think sitting is like a really easy thing that everyone should be able to do. It's just not. Do you have any good things you recommend?
Well, I always say to my clients that learning to sit is basically like doing an exercise. We can't expect people to just, I mean, I sit here without a back, but I've been doing this, I've trained myself to be able to do this. See me 10 years ago, there's no way I could sit up all day without a back support. I'd be like, it takes time to build that postural tone to hold yourself up. So, don't beat yourself up about, oh, I can't sit up straight. It's hard. It's really hard. Have you ever heard of sit fits? Really good for children. Have you heard of those?
No.
They're made by Sizzle, but I think you can probably get cheaper versions on Amazon, but Sizzle are probably the best. So they're little discs, like so big, and they're inflated by about that much, and they're wobbly. So they're like a softer wobble board. But they're called sit fits because they were designed to help people sit better. Because when you sit on one, it helps you sit up. You can't really slouch on it, but it's comfortable. So it's great. Children love it. I've got a lot of children who take them to school with them because, especially with sort of ADHD, etc., it helps them settle a little bit better. But they're great. Sit fits are really good. But again, if you get a sit fit, don't try and sit on it all day as soon as you get it, because you'll be in agony, because it is making your deep postural muscles work, even though you think, well, I'm just sitting on it. So as with any exercise, start with 10 minutes to sit, then build it up from 10-minute intervals until you can sit on it comfortably. But they're great. Children love them.
Love it. There's two things I think I've done, because again, like going back 10 years time, I was really struggling with this. I have not advanced to the point where I can do a whole webinar without back support, but I'll do bits of it. So progress is definitely happening. But the two things that I recommend most often, the first one is perfect posture peeing. So just for the duration of the time you are on the toilet, try to sit on the toilet with perfect posture, because it's a self-limiting time. It's something you repeat multiple times throughout the day. And it's often a time where you've got minimal distractions. So you can actually focus on, kind of concentrate on your posture without it being too much of a boring sidetrack from your day. And the other one is the roundabout game. So obviously only do this if it's safe to do so. And I would not start for this one. But what we started doing was, when I was a passenger in a car, when we got to a roundabout, I would try and sit up out of the seat and just balance for the duration of the time we were going around the roundabout. And when we first started doing this, when I was at my most unwell, Mum was driving me to and from university, and I, even with a seatbelt on, wedged into the seat, had to grab hold of the bar because I didn't have the core strength to sit during a roundabout. And by the time I finished my degree, I could sit up for every roundabout between Ipswich and Northampton. So, like progress for things like that, just try to find tasks that will challenge you a little bit, but like this much, but multiple times a day.
Movement snacks, aren't they? Build these things into your day. You don't have to think, oh, I've got to go and do my exercises. Like you said, while you're in the car or whenever. I love what do you call it? Perfect
posture peeing. Yeah.
Great one.
I like alliteration. But yeah, random things like, gym balls, sitting on gym balls.
Yeah.
It's hard to motivate yourself to do that. But if you spend the TV advert break on a gym ball, and you can get off it when your program comes back on,
yes,
it's easy to motivate yourself to try. So
well, and I'm just going to mention, I'm actually sitting on a wobble stool. I don't know if people have heard of those, but it's got a wobbly base. So again, I think they were designed for children. I got mine from Amazon from a company called School Fitters, so I presume they're for children. But again, a great way for me to work my postural muscles while I'm sitting, because I can't slouch because I will be falling off the back. So again, great for balance, great for proprioception, but again, build up to using it. Don't sit on it all day for the first day.
Fabulous. Okay, next question. Can we see Jeannie online, and do we have to pay for that?
You mean online consultations?
I think so, yeah.
So yes, I do things online. I have clients all over the world, actually. So yes, but those are paid for appointments. But I do also have the Zebra Club app, which is very, very affordable. And we do online stuff there as well. So, you know, I kind of try and cover so everyone has access. So the Zebra Club might be another option if you want to work with me online, but obviously it's in a group environment. But yes, long story short, sorry, yes, I'm waffling. Yes, I do things online as well. Sorry.
It's all right. Okay, next little one here. So are you seeing a lot of women with fibromyalgia and hypermobility in the UK? So this person is in Canada, and their knowledge seems to be a little bit behind us. You know, just in terms of considering the overlap of symptoms, comorbidities, fibro particularly.
Yeah, there's a great paper about that Professor Shay Palmer, I don't know, I think it's a recent one. It only came to my attention recently, where he actually examines, if you like reading academic papers, he actually examines how they are so, HEDS and fibromyalgia, how they're like this. They're so difficult to decipher. So yes, there are a lot of people with a fibromyalgia diagnosis who probably have EDS, or some people have fibromyalgia, then they get their EDS diagnosis on top of that. But yes, unfortunately, if people aren't, and that's the problem we have, isn't it? If people aren't aware of EDS, and we're all doing our best to raise awareness, but if there are still people out there who don't know about it, and so when they see people with widespread body pain, they go, oh, you've got fibromyalgia. They don't even think about hypermobility or EDS because it's not on their radar. So unfortunately, that's, I think, why we've got so many fibromyalgia diagnoses, which are not correct.
Yeah, I agree. I think all of the symptoms of fibromyalgia are symptoms of hypermobility EDS. So, you know, but what tends to happen is that people will get a diagnosis for 20 different symptoms, and then somebody finally goes, oh, hang on a minute, maybe it's all connected. So you see people who've got chronic fatigue syndrome, IBS, chronic headaches, fibromyalgia, Raynaud's, all these separate diagnoses. Actually, what they have is one diagnosis and a whole heck of a lot of symptoms. Yes. From my perspective, what you label something with, what we call it, what the diagnosis is totally irrelevant. We should be focusing purely on what each individual needs on a clinical basis. If you have symptoms, you need symptom management. If you have a diagnosis, great, fine. It makes the conversation simpler. But that doesn't mean that, you know, anyone who doesn't have a diagnosis should be lacking that same level of support. And I think that's one of the things I really like about our respective professions, is that we can just choose to ignore diagnoses and work purely on what people actually need. Whereas I think medicine is sometimes a little bit less open-minded about that.
Yeah. You've got to look at the person who's standing in front of you at that time, you know, and what do they need, and what are their symptoms, and how can I help? Who can I refer this person to get the help? You know, yes, we all, yeah, I see people who've got multiple diagnoses, but I don't go, oh, well, she's got arthritis, she's got scoliosis, she's got this, I need to treat them all individually. No, I want to treat that whole person, regardless of what all the individual little bits are.
Yeah. I would love to see us get to the point where when people are diagnosed correctly at the end of a 20-year journey, all of the first diagnoses are actually crossed out. Yes. Like if I could make medicine take up one new habit, that's the thing I would make them do. I think it feels to me, it feels better having one diagnosis that explains my entire life than carrying 10 miles worth of paperwork with me everywhere I go. It just, It is a recurrent frustration of mine, shall we say. But yes, there is definitely a strong correlation. And I think particularly ignoring gender and looking purely at kind of biological sex in the most simplest, most binary way possible, progesterone and estrogen do not do chronic pain patients any favors whatsoever, whereas testosterone can work absolute wonders. So yeah, those of us that have to put up with kind of monthly hormonal cycles do tend to have a worse run of things, and menopause tends to complicate things even further. So there is definitely a kind of hormonal element to chronic pain, which is not helpful or pleasant for anyone, and is often quite underappreciated by healthcare systems and under-supported, I think. So yeah, but I think you've got a separate kind of zebra club menopause thing. Yeah.
So within our app, we have different subgroups to support people. Obviously, we have people of all ages. So we have groups from teenagers to parenting groups to prenatal, and we have a menopause group. And we meet, we try and meet every 3 months or so, but we also have a private chat group. And gosh, yes, the symptoms are I mean, I'm going through it myself now. The symptoms are totally exacerbated for so many people once we hit menopause. And really, you're only just catching up with EDS, with the fact that the female hormones play such a critical role in how we feel and our symptoms. So yeah, puberty, pregnancy, menopause. Whew, lots of things could happen in those periods, unfortunately. See it all.
Yeah. I normally say to people, if you can get as far as menopause and you're still asymptomatic, you're fine. No, you'll stay asymptomatic, but normally it will get you either from birth or at puberty or from your first pregnancy or at menopause.
Yeah.
Those are tends to be the onset time for so many of us.
Yeah.
Yeah. Okay. We had a question here specifically about chest pains, which is a very kind of medical cardiologist specialist question that neither of us are qualified to answer. So, yeah, if that question was from you, that's really something a cardiologist should be looking into, and it's not something we can particularly advise on. So I would definitely say go back to your GP and request a second opinion. But equally, there are an awful lot of hypermobility related, fairly benign but very unpleasant causes for chest pain that could also be investigated. Costochondritis, I can never pronounce that right, but yeah, that's one of the ones that it feels like you're having a heart attack, but actually it's not. There's no kind of cardiac component to it at all. So costo would be worth looking into, but other than that, I would definitely speak to a cardiologist about all of that one. Any advice regarding nutritional therapists for hypermobility, specifically for kind of histamine type issues? Do you have a person you refer to specifically, or an approach or anything?
Yeah, I mean, it depends where you are in the world. We now have, there are a number of, there's a dietary consortium, and there's 2 people in the UK who are on this consortium. One is Lorna Ryan, and one is Helen Spriggs. One's based in, well, I know they do online stuff. And then there are at least 3 people in the States who probably also do online stuff. Bonnie Nasser is an American who specializes in MCAS. Was it MCAS you mentioned?
Yeah, histamine intolerance, but yeah, similar.
Nasser is the person I know who specializes in MCAS. She's based in the States. But Lorna or Helen would also be knowledgeable on that.
Lovely. Thank you very much. Somebody here uses a manual wheelchair. Is finding like tension in the upper body. Kind of, have you got any advice for that?
Manual wheelchair. Yeah. So what I'd be interested in, as I said, I look at movement patterns. So if you're using a manual wheelchair, I'd be interested to understand how you're actually using your arms to do the action of moving the wheelchair. Because a lot of what I do with people is actually, it's amazing how so many of us, me included, don't know how to use our arms properly. And so we end up just using this bit or using the front body, and when our shoulders are up here and we lock our elbows and we lock our wrists and all sorts of things. So teaching that the arms are actually coming out of your deep postural muscles on the back, and all these muscles down here are part of your arm. Your arm doesn't finish here. We think it finishes here, but it's being fed all the way down to the back of your pelvis. Those are the strong guys. So if I'm using a wheelchair, I want to make sure that I'm recruiting these muscles at the back, not relying on these little muscles here and my pecs that are going to get really tight and sore, and my neck that's going to get really sore. So again, look at on my YouTube channel, I've got a class on shoulder stability. That would be fantastic. It would teach you how to access your posterior muscles, understand a bit about shoulder organization. But without seeing you, but I would imagine a lot of that is coming from how the arms are actually being used. And if you lock your elbows in any of that process, that's going to go straight up into your shoulder. So we've got to check the elbows as well.
Yeah. We had a follow-up question about splinting here. So this person doesn't get injured, but a medical professional recommended splinting anyway. So they tend to splint for pain rather than for anything else. The question is, should I for long-term protection, should they be splinting to avoid getting more lax?
No, I think it's the same. I think as long as you're doing rehab or exercise or movement or activities, I don't see there's a problem with that, unless I've misunderstood the question. But no,
I don't think so. I think that as well that the type of splinting you're using should be considered. So for a pain management perspective, I often would recommend compression for pain, simply because it retains warmth, it promotes good posture, but it's not too restrictive. Yeah. Whereas if you're looking at managing injuries, subluxations, dislocations, sprains, you may want something a bit more restrictive to allow your body to offload a bit and to heal. So you may find that from a pain perspective, compression is great. If you're looking at an injury or risk avoidance perspective, then something maybe a little bit more heavy duty, start bringing in your metal work and your Velcro. So just think about maybe what you're using. If in doubt, get yourself an orthotics referral. It is perfectly acceptable and often very sensible to have multiple splinting options for the same body part if you do a lot of different activities. So I think I've probably got 4 sets of wrist braces at this point. Sometimes I'll wear none for 2 or 3 months at a time, but when I need them, they're a game changer. So yeah, trust your instincts on that one, but keep doing your exercises, I think is the best advice.
I think that's a really nice idea, said that you've got different types of splints for different activities. You know, I think people think it's possibly one thing and that's it, but that's really a nice idea that you can have a whole sort of selection to choose from depending on what you're doing.
Yeah. Lovely. Can hypermobility cause a larger tear in the supraspinatus muscle and fatty atrophy, and a tear in the infraspinatus subscapularis tendons and the long head of the bicep? Any advice on repair and rebuilding?
Well, yes, the shoulder joint is probably one of our most vulnerable joints. Again, you've been reading my mind because I was doing research today about shoulder instability and injuries, etc. So yes, it's probably the most common injury point for hypermobility. So it could tear any of those muscles depending on what you're doing. And you know, the thing to manage that, obviously, again, shoulder stability exercises. But before you even think about shoulder stability and strengthening, alignment. You know, is my arm bone actually sitting in the right place? Do I understand the mechanics of my arm? Again, that video I mentioned earlier, I go through that. Where should my arm actually be sitting? Is it here? Is it here? So I teach you all of that. So you got to get alignment first before you think about stability and strengthening work. And yeah, and again, I don't obviously know your history, but depending on how severe it is, I presume you maybe have seen a physio or somebody else to assess that for you, to check what's going on.
Lovely. We're pushing for time, so I'm going to whiz through some more. I have long-standing problems with rigid thoracic spine that is getting worse despite physiotherapy, hydrotherapy, exercise referral scheme for chair aerobics and aquatherapy. previously keen Pilates participant, had reached a high level of ability in 2018 to 2020, but it was deteriorating. So they've had to kind of quite drastically reduce from advanced to medium and then basic. So it kind of working down the scale here. Their instructor is hypermobility aware, has advised they sit out with ketones. Current physios has lots of bridges and standing pelvic tucks, but the pain is kind of getting worse. And kind of rib instability is starting to become a thing as well. Can this type of rigidity be improved? And if so, where should this person start?
So that's thorax, you said, thorax. Yeah. So this is a common problem that I see in probably 99% of people who come to see us, for that reason that I mentioned earlier, that we adopt a fixed rate. I don't mean bracing as in braces, I mean guarding, a fixed kind of rigidity in our thorax a lot of the time, which impacts our breathing, impacts our postural and muscular tension. You know, as you know, my background was Pilates, but I had to modify a lot of that Pilates repertoire because it just isn't suitable for us. There are lots of things I don't do anymore in the Pilates repertoire because they just weren't suitable for my body. So can that rigidity change? Absolutely, yes. So we have to look at why is that gone rigid? You know, can we, again, it's that habitual tension. Can we start to let some of that go? Because if this is really rigid and this isn't moving, it's going to be painful. Yeah, because all your muscles are going to be in constant contraction. And the other issue you have is that if this bit isn't moving, your neck and your lumbar spine are going to start moving more. So you're going to have more mobility up here and down here. And what we want to try and do is find balance through the whole spine, so that the forces are going through the whole spine. That's what the spine is. It's a big shock absorber, and that's what it's designed to do. So yeah, I see this all the time. How do we start working on it? Back to breath and relaxation. First of all, allowing some of this weight, lying supine on the floor, whether you need cushions, blankets, whatever it is, get yourself comfy and just start to breathe and feel the weightiness of your thorax. Can you actually let that go? And you might find that that's quite challenging because you've got into a pattern of holding yourself quite rigidly. If we can let this go, you're going to have a much better chance of getting back to enjoying full Pilates or whatever it is you'd like to do type movements. Okay, but yes, there's definitely a way back.
Fabulous. The next question is actually on mid-back pain as well. So kind of where your bra straps, a lot of muscle tension and pain. So I think you've kind of answered that one already. The only other thing I would say from a pain perspective, TENS machines are fantastic for back pain. Yeah. And it's the sort of thing you can combine with heat, with movement, with laying down, with ibuprofen, with painkillers, with all kinds of other stuff. So TENS machines now you can pick up from pharmacies for about 25 quid often, and it is well worth the investment. I think the only contraindications for TENS are if you have external fixation metal work at present, or you're actively undergoing cancer treatment in the form of chemo or radiation. Even then, there may be exceptions, but you need to check with your kind of consultant for that. So TENS is generally speaking a very safe long-term pain management strategy that I particularly do recommend for back pain. So definitely have a check with that. If you can get the pain down with TENS, it often means that you're spending large chunks of the day not doing those bracing, tensing behaviors that we've just learned about. So it can be really beneficial to just get the pain under control, and then you can start doing your breathing and your relaxation, and hopefully it all comes together a little bit. Okay. Oh, we are out of time. We are out of time. How did we do? We've got quite a few questions left, but not a horrendous amount. USB rechargeable TENS machines are available online. Brilliant. Love it. Are TENS machines okay with high blood pressure? I think so, but if in doubt, check with your GP. I've used TENS extensively at times where my POTS has been really quite out of control, and I've never noticed a correlating problem. So yeah, I think it's okay, but double check with your GP if you're in any doubt whatsoever. I'm deliberating on whether to just cram the last few questions in, but not to take any more. Otherwise, I'm going to have to bring you back for a whole new week, and we'll have like a never-ending list of questions. Okay. So, is there a particular sort of desk chair you'd recommend or not recommend for hypermobile EDS? I was advised to get a very supportive chair, advised by a specialist company, but found it too kind of strict because this person needs to fidget. Wonder if there's an active seating option that would provide this while also managing the fatigue over the course of the day.
That's your area.
Yeah, I hate questions like this. I wish there was a chair that I could just go, this chair, this one piece of equipment suits all bendy people. You'll love it. There isn't. The best advice I can give is to go and sit in as many different pieces of furniture as you can and then buy the top 3 for trials. Same for mattresses. Go and lay in them. Block a whole day off to go bed shopping and spend 20 minutes on every mattress before making your decision. It is very, very difficult. Best case scenario for things like desks, chairs, and beds is if you've got multiple variations within a single product, it will meet your needs a higher percentage of the time. So if you can adjust whether you've got armrests, if you can adjust the lumbar support, if you can fidget with that kind of thing, yeah, it's likely to be more adaptable to meeting your needs, certainly. But yes, I wish it was as simple as that. And I'm sorry that I can't give you a go buy this thing for 20 quid because it's perfect. I wish there was. I wish.
I think that's the thing, isn't it? There is, for anything we're talking about, there isn't a one size fits all, unfortunately. So we're all of us listening today are so different, all of us.
Yeah. Okay. Any thoughts on the Baton score being too stringent? A recent paper was published that suggested it needs a whole new revamp. I have many thoughts. I could do a whole webinar on just that. I'm guessing you probably feel the same way.
I mean, the Baton score is so many life-changing decisions are made on a Baton score. People are told, well, you scored low on the Baton score, so you're not hypermobile. I'm sorry, that is just incorrect. You know, remember the Baton score only looks at a few joints in the body. It doesn't even look at shoulders, which are our most problematic and mobile area. So I don't take any notice, I don't take any notice of people who are told, it's just wrong, it's just wrong. And then you look at them and they're clearly hypermobile. So that shouldn't be the be all and end all. But again, because of lack of awareness and education, some people just do the Baton score and say, oh no, there's nothing, which is just incorrect. The Baton score is a starting point for a whole discussion about EDS and hypermobility. But sadly, that doesn't happen in some cases. So yes.
Some of the bendiest people I know score 3 or less. Some of the most physically fit professional athletes I know score 9 out of 9.
Yeah, exactly.
Yeah. Simple as.
Bigger discussion. It shouldn't be the all and end all, and people's lives shouldn't be decided upon because of that one score.
No, very much agree. That is the end of the questions, but I have had a message just kind of calling me out on oversimplifying things, which I will admit to have been done. There are going to be people who have multiple diagnoses, and all of those separate diagnoses are right. I'm absolutely not saying that everyone who has EDS only has EDS. But the vast majority of the time, when you see somebody who is diagnosed over the age of 30, they have a long trail of things that can all be attributed to the eventual correct diagnosis. And it's on those situations where I think if you could just cross all of that out and write a nice explanation about what connective tissue disorders actually entail, it would be a clearer treatment pathway and a much less confusing and much more effective situation for a lot of people. But yeah, it's not a perfect system. There are going to be exceptions to every rule. So yes, I apologize for oversimplifying that and making it seem like I was dismissing those experiences. But yes, hopefully that makes a little bit more sense. Okay, we have successfully reached the end. Thank you very, very much, Jeannie, for joining me and for all your amazing knowledge. It's been just Incredible to have you, and thank you very much for sharing everything with us. And I hope I can convince you to come back at some point later on when I've worked my way through the rest of the medical advisors.
I'd love to come back, and thank you everyone who came, and thank you for inviting me, and always a pleasure and an honor, so thank you.
Thank you. So I will be back third Thursday of every month. We have different people for different ones. Sometimes it's just me on my lonesome. Coming up fairly soon-ish, we have the classic seasonal coping strategies for December, which has major seasonal events for pretty much every faith, religion, or everything else. So we're all exhausted and over socialized by the end of it. So I tend to focus December on how to cope with the peopliness that is the festive season. But yeah, other than that, I'm hopefully going to have a few more wonderful experts with me at various times. So keep an eye on the events. Even if it is just me, please still turn up because I love doing these. If you've got healthcare professionals that want to learn more, I am very soon on the 22nd of November starting a separate live stream specifically for healthcare professionals to come to. So it will be similar to this, but looking at things from a more clinical setting. That one is not open to patients, members of the public. What it is there to do is to educate your doctors, your physios, your OTs, your dentists, and your everyone else. So if you think your healthcare team needs a knowledge update or a boost, please point them in the right direction, and hopefully we can get them up to speed with your level of knowledge and everyone gets better care in the end. So yeah, thank you all very much for coming and enjoy the rest of your evenings. Take care. Bye.
Bye-bye. Thank you, Jo.
Fabulous.
Thanks, lovelies. We'll just make sure we're clear.
Yeah.
You guys are amazing. We appreciate you.
Thank you. We appreciate you.
Thank you.
I need to pin you down when you know your schedule, Jo, for next